Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hey everyone, I am the Millennial Mechanical Therapist, and today I want to go along the same lines of the videos we've been doing this week about how important it is to truly thoroughly go through a repeated movement assessment with any of your patients. The case I want to talk about today is a middle-aged woman who came in with low back pain that has been termed a chronic low back pain, and she's had this pain for about 3 years now. She has a diffuse ache throughout the whole lumbar spine, and it went equally right and left, and she gets intermittent bouts of sciatica. Now, she only came because she originally had an acute exacerbation of her sciatic pain, and her doctor had recommended physical therapy. By the time she truly got to the office, she was kind of at the tail end of the natural history of the sciatic pain that she was experiencing, and she really didn't have too much. That kind of left us with this diffuse low back pain, and going through the evaluation and things like that, especially the assessment, it started sounding like her low back pain was more mechanical than anything else. Accordingly, as we went through the rest of the exam, we found a couple neurologic signs. She had left dorsiflexion weakness, and she had some numbness and tingling going down the left leg that she hadn't really reported previously. So as we continued through the exam, we went through quite a few different repeated movements that offered some relief. Originally, it started with extension and standing. She did get some relief from that. Her neurologic signs improved after doing that. Going on from there, she ended up responding to a modified kind of press up, the technique where you stand at the edge of a table and just kind of let the hips dip down and in. Oftentimes, this is provided with our patients that are currently pregnant. With this patient, she had some comorbidities that really restricted her ability to lie in prone. So I went with that variation. As she did that exercise, she improved, but she remained having some low back discomfort for the majority of her day. As we continued to dive through, we exhausted the options we had in the sagittal plane. So accordingly, we kind of went off into a coronal direction to try to find if that would affect how symptoms are. We went through different variations of that modified plantigrade press up there, and we did it with 1 foot up on a stool on either side, trying to kind of shift the hips off and impart a bit of a side glide during that. At the end result, after going through the whole assessment, it ended up that she responded very well to the point that she abolished her pain with extension and standing while in about a 50% side glide to the right. In order for her to do that, what we did is we had her up against the wall, perpendicular to the wall, so that she was in this position, and then she had one arm up, imparted that side glide as far as she could and backed off about half, and then performed extensions in that position. That's very similar to doing a manual shift correction. The very end parts for the MDT progression there, you impart that full side glide and that shift correction, and then you back off a little bit and have the patient extend over top of you while you're imparting that correction. As she performed that, and mind you, there was no noticeable deformity, she did not present with a lateral shift, she performed this motion and abolished her pain. About a week and a half later, we were able to jump into the recovery or function phase, and since then she's been discharged and follows up with me via phone, and she reports no recurrence of her pains. So that case is one of many that I know I have and Joe has that really bring to light the need for a thorough repeated movement assessment. Now, if you go through and you do the standing versions of everything, and you do side glide either side, extension and flexion, and you find no directional preference through those, many of the clinicians that I've worked with kind of just bail out from there and go on to a different approach. And that's not necessarily saying it's the wrong thing to do, but perhaps they're kind of missing the forest for the trees at times when you do that. Just because they don't respond immediately to those basic progressions, some of the alternatives are just as helpful, and I think this case really highlights that from my career so far. I want you guys to just kind of take that one grain of salt in there, take it with all the other videos we've been presenting this week, and just maybe sit down and think about what's going on, and if you're not screening your patients thoroughly enough for the repeated movements. As always, guys, you want to move your patients early, you want to move them often, you want to move them to end range especially. That's where the magic happens. We'll see you guys next time.